Hello and welcome to this craniofacial video. I am Tanya Chamberlain from the Division of Anatomy here at the University of Leeds, and in this video we will be looking at the craniofacial features including the palate and the thyroid. After this video and any further study, you should be able to describe the structure of the sutures and the synchondrosas, indicate the major sites of postnatal skull growth, give an account of the anatomy of the palate, review the thyroid and the cricoid cartilages, and describe the position of the thyroid gland within the neck. But for now, let's have a look at the development of the skull. If we don't include the ear bones and the hyoid, the skull is made up of 22 bones, the majority of which are paired bones, which thankfully means we only have to remember half the names. These bones, over the pre- and postnatal years, continue to grow to accommodate for the brain and facial development and form something called sutures, or synchondrosas. These create a case for protecting the vital soft tissues within the skull, such as the central nervous system, the eyes, the upper respiratory tract, the auditory tract, and the oral cavity. We have two regions of the skull that we need to take into account. The viscerocranium is described as the bones that make up the face. It can be subdivided into nasozygomatic maxillary complex, known as the upper face, and the lower face, which is the mandible. The viscerocranium consists of the inferior nasal concha, the nasal bone, the maxilla, palatines, lacrimal bones, zygomatic bones, all of which are paired, and then we have the unpaired vomer and mandible. Whilst the neurocranium is the box that holds the brain. This is also divided into two parts: the calvaria, which is the skull cap that sits over the brain, and the cranial base, which is where the brain sits. The neurocranium consists of the frontal bones, parietal bones, occipital bone, ethmoid bone, sphenoid bone, and the temporal bones. So the key points to take away are: the skull is made up of 22 bones, not including the hyoid or the ears. Most of these are paired, and they articulate via something called sutures, except the mandible. We have two parts. We have the viscerocranium, which are the facial bones, and the neurocranium, which house the brain. If you need to recap these bones, please visit this video below for a step-by-step walkthrough of the bones of the skull. The words sutures or synchondrosas are going to be thrown about throughout this video, but what are they? Well, although formed differently, there's a lot of overlap between the two terms. Sutures of the skull, also known as cranial sutures, are fibrous joints with fracture-like appearance found between the bones of the skull. Sutures are formed during embryonic development. They are signs for bone expansion, ensuring craniofacial growth during embryonic, postnatal, and later growth periods. The cranial sutures ossify at different rates, but most of the sutures have ossified by the age of 20. Synchondrosas, however, are slightly different in that they are not fibrous joints, but instead are cartilaginous joints, which are found at the base of the skull and the mandible. Both sutures and synchondrosis are synthroarthrosis joints. That means they don't move, and they are formed between the embryonic stage and over the first 20 years of life. Depending on the age and the skeletal growth stage, the different sutures are seen at different stages of fusion and ossification. Many sutures join together at the bones of the skull. They connect and form junctions with each other. Sutures can be further subdivided according to their location, and the sutures of the neurocranium, sutures of the viscerocranium, and the sutures between the neuro and viscerocranium. The latter are seen on the border between the cranial bones belonging to the neurocranium and those belonging to the viscerocranium. Sutures and synchondrosas are something we have compromised on throughout evolution. Any area in the body that forms a link is an anatomical weakness. We see this throughout the body in blood vessels and in synovial joints like the knees and the elbows. The joining of two bones forms sutures, and synchondroses are no exception to this rule. They are weak sites and susceptible to damage from trauma. Given that the skull is supposed to protect the brain and the vital structures of the eye, mouth, and nose, why have we evolved to have these weak areas? Well, due to the enormous size of our head in relation to the birth canal, in order for us to be evacuated during vaginal birth, the skull must be compressible. We need it to be malleable. It does this due to underdeveloped cranial plates that form spaces called fontanelles. We will look at these in a few minutes. Additionally, our viscero and neurocranium need to grow to accommodate our increasing brain size, so being able to form sutures has become necessary for allowing brain development and increasingly large size, which we can be seen with the changes of portions allocated to each region of the skull, from neonate to adult. The rate at which sutures fuse and ossify is physiologically relevant. During birth, the fibrous joints provide a malleable quality to the child's head to allow the bones to move. In neonates, the sutures are completely fused, leaving membranous gaps called fontanelles. Fontanelles are also called soft spots. There are 6 fontanelles: the frontal, the occipital, 2 mastoids, and 2 sphenoid fontanelles. The lateral pressures on the skull during birth allow for superior displacement of the parietal bones for easier passage, which can remain displaced for a few hours post-birth. The fontanelles form sutures. The coronal suture forms over the frontal fontanelle. The coronal suture is seen on both lateral and superior sides of the skull. It is formed at the junction between the parietal bones and the frontal bone. It runs horizontally across the superior part of the skull. In the middle, it intersects with the opposite coronal suture and the metopic and sagittal sutures. The coronal suture usually fuses around 2 years old and ossifies completely at around 24 years of age. The squamous suture, named after the squamous part of the temporal bone, forms the suture between the temporal and parietal. This is paired with one left and one on the right side of the skull. The lambdoidal suture forms at the occipital fontanelle and forms between the occipital and parietal bones. The lambdoid suture is an inverted U-shaped suture seen on the posterior cranium. It is formed at an articulation between the superior border of the occipital bone and the posterior border of both parietal bones. In the middle of the posterior cranium, the lambdoid suture meets the sagittal fissure, forming a landmark called lambda. It is shaped like the Greek letter lambda, which it is named after. The lambdoid suture usually ossifies around the age of 26 years old. The occipitomastoid suture is formed from an articulation of the squamous part of the occipital bone and the temporal bone's mastoid part. It looks like an oblique continuation of the lambdoid suture. The occipitomastoid, parietomastoid, and lambdoid sutures intersect on the posterolateral sides of the skull and form a landmark known as the asterion. The occipitomastoid suture ossifies around the age of 16. The sphenofrontal is seen on the roof of the orbits. It forms at the articulation between the greater rings of the sphenoid bone and the frontal bone. The sphenofrontal suture ossifies at the age of 15 years old. Laterally to the sphenofrontal suture and intersecting with it is the sphenoparietal suture. It is a short suture between the greater rings of the sphenoid and the angle of the sphenoid on the parietal bone. The sphenosquamous suture is found on both lateral sides of the skull. It is a vertical suture between the anterior aspect of the temporal bone's squamous part and the greater ring of the sphenoid bone. It usually ossifies around the age of 10. One very significant suture is this one. This is the pterion, the joining of the sphenoid, parietal and frontal, and the squamous part of the temporal bone. As said previously, the joining things in anatomy are weaknesses, and this area is a prime example of this. And the weaknesses in this can be devastating. Immediately beneath this pterion is the middle meningeal artery, which branches from the maxillary artery and moves into the neurocranium to supply the meninges of the brain. The area of the skull is also the thinnest area, and a blow to this area can result in the fracturing of the skull and the rupturing of the artery beneath it. This would present as an extradermal hemorrhage which can result in significant neural deficits or even death. During embryological development and childhood, sutures form as intramembranous bone growth sites and only fuse and ossify later in life. New bone is produced at the sutural edges as a result of scrupulously coordinated external stimuli. Delayed or restricted bone growth results in suture agenesis and wide open fontanelles. Moreover, excessive bone growth can also result in deformities of the skull. The frontal fontanelle closes between 12 and 18 months of age. The occipital fontanelle, also known as the posterior fontanelle, is located at the junction between the sagittal and the lambdoid sutures and usually closes around the 1st and 2nd months of age. The minor fontanelles are paired. They are smaller and situated on the sides of the skull. These are the sphenoid and mastoid fontanelles. The sphenoid fontanelle is located between the sphenoid, temporal, frontal and parietal bones, whilst the mastoid fontanelle is situated between the temporal, occipital and parietal bones. That was a lot of information, so let's go and have a look at our learning objectives to remind ourselves of today's task. So now we have covered the sutures, let's move forwards and look at the anatomy of the palate. The palate is divided into two regions. The hard palate that is formed from the palatine process and the alveolar process of the maxillary bones and posteriorly by the two palatine bones. The hard palate forms 2/3 of the entire palate. Posteriorly to the hard palate, the soft palate or the velum lies. Both palates are lined with epithelial tissue and are continuous with each other. There are no bony components in the soft palate, but 5 paired muscles allow the palate to move. The tensor veli palatini and the vata veli palatini are 2 muscles that arise from the base of the skull and descend into the palate. During swallowing and yawning, these muscles tense and elevate the soft palate. The palatoglossus muscles ascend from the sides of the tongue into the palate, and the lower soft palate onto the tongue, narrowing the oropharyngeal opening as the palatoglossal arch. The palatopharyngeus muscles ascend into the palate from the posterior border of the thyroid cartilage. These muscles tense as the soft palate, whilst elevating the pharynx during swallowing, and can be seen in the oral cavity as the palatopharyngeal arch. The final muscle of the soft palate is the musculus uvulae, which arises from the posterior margin of the hard palate and passes into the mucosa of the uvula. It elevates and retracts the uvula. The general sensory innervation of the palate is supplied by a maxillary branch of the trigeminal nerve, or cranial nerve 5, through the greater and lesser palatine nerves and the nasopalatine nerve. The motor innervations of the muscles of the soft palate is by the pharyngeal branch of the vagus nerve, or cranial nerve 10, via the pharyngeal plexus of nerves. The exception to this is the tensor veli palatini muscle, which is innervated by the mandibular branch of the trigeminal nerve, or cranial nerve 5, via the medial pterygoid nerve. The palate also receives autonomic innervation, parasympathetic secretomotor fibres to its mucosal glands, and sympathetic fibres to its blood vessels. The main arterial supply of the palate is by the descending palatine artery, which is a branch of the maxillary artery within the pterygopalatine fossa. It runs through the palatine canal and gives rise to two branches, the greater and lesser palatine arteries. The greater palatine arteries enters the palate through the greater palatine foramen on each side, close to the second molar tooth of the upper jaw. The smaller, lesser palatine artery arises from the descending palatine artery within the palatine canal and enters the palate via the lesser palatine foramen. So let's revisit the learning objectives before moving on to part 3 of this video. Now we have covered the sutures and the palate, let's have a final recap of the thyroid and the cricoid cartilages of the larynx and view how the thyroid gland sits within the neck. Here we have a view of the larynx and the pharynx. The two cartilages we are concerned with today are the thyroid cartilage and the cricoid cartilage. This is the thyroid cartilage, on which the thyroid gland sits. On the image on the left, we are looking at the cartilage from a posterior perspective, with the right side of this image having been cut away to reveal some of the structures that otherwise would have been obscured. The image on the right is looking at the thyroid from a lateral perspective, with the anterior being here and the posterior or the back being here. On the anterior of the larynx we have this bulge or this prominence. Because it's of the larynx, this is the laryngeal prominence, or as it is also known, the Adam's apple, which is an important landmark for locating the bifurcation of the common carotid artery. Being the biggest cartilage of the larynx, let's have a look at a couple of the features of the thyroid cartilage. The first one is the superior horn of the thyroid cartilage. The superior horn provides attachment sites for the thyroid membrane, whilst the shorter and thicker inferior horn of the thyroid cartilage articulates with the cricoid cartilage below it. We have two superior and two inferior horns, but the right ones have been cut away on this image to reveal the structures within the larynx. Below the thyroid cartilage, before the larynx transitions into the trachea, we have the only complete circular ring of cartilage. This cartilage is the cricoid cartilage, and it is similarly shaped to a signet ring. It forms the inferior aspect of the larynx and is connected to the trachea inferiorly. It is the only complete ring of cartilage that encircles the airway. The cricoid cartilage has a narrow arch or band portion and a wider posterior lamina, the signet portion, with a midline ridge that serves as the surface for the attachment of the esophagus. A dense band of connective tissue, the cricothyroid ligament, attaches the cartilage to the thyroid cartilage. The cricotracheal ligament attaches the cricoid cartilage to the first tracheal ring. The larynx is a complex hollow structure located in the anterior midline region of the neck. It is anterior to the esophagus and to the level of the 3rd to the 6th cervical vertebrae in its normal position. It consists of a cartilaginous skeleton connected by membranes, ligaments, and associated muscles that suspend it from the structures surrounding. It sits just above the trachea and is continuous with the oropharynx. That's the portion of the throat posterior to the oral cavity. The larynx conducts air into the lower respiratory tract and closes off airway, especially during swallowing, to prevent aspiration of food. It's commonly referred to as the voice box or the organ of phonation, as it houses the structures responsible for sound production. It's quite mobile in the neck, and it can be seen and felt moving upwards and forwards during swallowing, closing off the trachea and opening the esophagus. The thyroid gland is a butterfly-shaped gland, vascular in red and brown endocrine gland situated above the midline of the anterior neck. Under normal circumstances, it extends from the level of the 5th cervical vertebrae to the 1st thoracic vertebrae. On average, the gland weighs between 15 and 25 grams. and it is the largest of the endocrine glands. The irregular structure is encased in pretracheal part of the deep cervical fascia. It is made up of a central isthmus that connects the right and the left lobes of the organ inframedially. Between the ages of 8 months to 15 years, the thyroid gland appears the same in both males and females. However, the gland is slightly heavier in females over the age of 15 than in the male counterparts of a similar age. Each lobe is roughly conical in shape, with the apex pointing superolaterally and their bases inframedially, between the 4th and 5th tracheal rings. At their widest point, each lobe measures around 3 cm in the transverse plane and 2 cm in the antero-posterior dimension. The lobes are roughly 5 cm long. The isthmus lies above the 2nd or 3rd tracheal cartilages and measures about 1.5 cm in both transverse and vertical planes. In some individuals, there may be a 3rd lobe of the thyroid gland, known as the pyramidal lobe. It is also conical, that extends from the isthmus up to the hyoid bone. In some cases, it may also arise from the inframedial aspect of either the left or the right lobes, but it is more commonly seen arising from the left lobe. The major laryngeal cartilages provide a scaffold for the thyroid gland. Posteromedially, the gland is attached by the lateral thyroid ligaments to the cricoid cartilage. Additionally, the levator glandulae thyroidae, the levator of the thyroid gland, which is a fibromuscular structure, also anchors the isthmus or the pyramidal lobe to the hyoid bone. And that brings us to the end of this video. You should now feel confident in applying any additional self-directed learning to the topics we have covered today to reach the learning objects as part of your module. You should now be able to describe the structure of the sutures and the synchondroses, indicate the major sites of postnatal skull growth, give an account of the anatomy of the palate, review the thyroid and cricoid cartilages, and describe the position of the thyroid gland within the neck.